Hello, and welcome to today's webinar, Pathways to Home, Taking Care of Our Chronically, Gravely Disabled Homeless. I am Alyssa Curtis, and I'll be the moderator for the webinar today, presented by the National Healthcare for the Homeless Council, with support from the Health Resources and Services Administration and the Bureau of Primary Health Care. This session is being recorded. This is a 60-minute presentation with the last 10 minutes reserved for Q&A. There's a chat box below the presentation slides for participant questions and technical issues. Please type your questions or any tech issues into that chat box at any time during the presentation. If you do type a question, please include your state as part of that question, because the answer will sometimes depend on what's available in your state. A select number of questions will be answered at the end of the presentation during the Q&A session. Any remaining questions will be logged and provided to the presenter for written responses after the webinar. If you're having technical issues, you may also call the Council's office at 615-226-2292 for assistance. Today's learning objectives are to discuss the history of deinstitutionalization in the United States, explain the legal definition of gravely disabled, discuss the vulnerability of those who are gravely disabled and should be evaluated for guardianship and/or long-term psychiatric treatment, introduce first responders checkoff list for the gravely disabled. And for your reference, there is a web link box at the bottom right of your screen. In that web link box, there is a link to the state standards for involuntary treatment. You can also access that information from the link on your screen. With that said, I would like to introduce our presenter for the day, Dr. Susan Partovi, the Medical Director at the Homeless Healthcare in Los Angeles site. Dr. Partovi, take it away.
Hi, everyone. Just a couple of things. I do have dogs, so I apologize in advance if there's any barking, and I'll try to shush them as quickly as possible. But I just wanted to start off, let's go to the beginning slide. Just wanted to start off to explain where some of this came from. And as most of you who are on the streets know, the most difficult people that we engage as far as getting them any kind of help, especially housing, are the severely mentally ill homeless. And if you look in your county, I would bet that there is not a program that aggressively tries to take care of this population. For example, in Los Angeles, we do have a program for the mentally ill, but it's for those who are willing to be treated, and so not for those who are unwilling. So we end up having a large amount of people that I call the super dupers. So for lack of a better word, I tried calling them the chronically gravely disabled, but our medical director of Department of Mental Health didn't really like that. But anyway, the super dupers are the ones that rarely take any help from us, or maybe don't engage, usually filthy, usually have been there in the same spot for years, usually well known to the community, usually filthy, and sitting in their own pee and poo. So that is what inspired me to really look into, how can we better take care of them? How can we streamline care for them? So just to introduce you to sorry, my dogs are playing. There is the Treatment Advocacy Center, which, if you haven't heard of this organization, it is extremely helpful. They are very much in favor of taking care of this population, the population that is often going in and out of hospitals, on the streets or in the jails, and yet there's so much backlash into really taking care of them. So they have a lot of research. So this state standards for involuntary treatment, actually, if you want to click on that and find your state's law around involuntary treatment, you can do that now, and then that way, of course, I'm speaking to mostly what we did for California, so that way it kind of, you can compare and see how you would take what we discuss to your state laws. All right, so one of the things is, in addition to the Treatment Advocacy Center, which was founded by E. Fuller Torrey, who is a psychiatrist who used to do street medicine in the 80s and 90s, he founded this organization, but he's also written several books. And so one of the books that I've used that's really helpful in looking at the history of the U.S.'s laws in dealing with the severely mentally ill comes from a book called Out of the Shadows, Confronting America's Mental Illness Crisis. So just to get us a little bit oriented to why we're actually where we are today. So institutionalization in the U.S. actually started in the 1800s by Dorothea Dix, who really was a proponent for humane treatment of the mentally ill, and in her desire to create humane treatment, she was the one that created the public hospitals. And they even called it, that time period, the era of moral treatment, which is interesting, right? Because our culture tells us that public hospitals are the era of immoral treatment. So in the early to mid 1900s, the hospital numbers became overwhelming. They became quite disgraceful. There's a huge piece in Life magazine in 1946 that shows the shameful practices of public hospitals. And so there was this national movement for reform, that even Mrs. Roosevelt was in favor of. And I think all of us would be in favor of reform, because when we see someone who's being treated wrongly, we want to right it. And so what started happening is that civil rights lawyers actually started getting involved and organized for the rights of the mentally ill. And so, as they were supporting civil rights for, say, African Americans, they were supporting civil rights for the mentally ill as well. 1964, DC was the first, I don't know, not a state, but first place to change their laws, where they only really included dangerousness. And if you look at California, we kind of led the way. In 1967, we have the Letterman-Pettis-Short Act, LPS, which really reined in the ability for involuntary treatment. So it restricted them basically to dangerousness and gravely disabled. And really their intent was to close state hospitals. And then in the late 70s, most of the states followed suit. So interesting, I found, was that the single largest cause for deinstitutionalization was Medicaid. And so what basically ended up happening is the state and local governments that were originally paying for mental illness care, they basically switched it to federal funding, which is Medicaid, which however didn't and still doesn't cover most psychiatric treatments. So for example, in California, Medicaid will allow for 3 days, so hence the 72-hour hold, for inpatient psychiatric treatment. Medicare, I believe, covers like 100 days. So, and then nursing homes start becoming the recipients of the severely mentally ill because Medicaid pays for nursing homes. However, nursing homes aren't usually the best place for the severely mentally ill. Okay, so so the consequences of deinstitutionalization, we talked a little bit about that. So basically not really addressing their actual needs. So for example, if someone needs to be in a hospital longer than 3 days, it's very difficult for that to happen, mostly because there's no funding for it. And we talked about using nursing homes, you know, not necessarily trained, nor are there full-time psychiatrists. And using general medical hospitals for psychiatric hospitalization is very expensive, and they tend to turn away the severely mentally ill and the homeless and those that are involuntarily admitted, and just not well-coordinated care. Okay, and as much of us know, the results of deinstitutionalization is, of course, what we see, which is the increase in homelessness. So the Treatment Advocacy Center states that 1/3 of the homeless population in the U.S. are mentally ill, and those, so interestingly, or not interestingly, 20%, so there's, just looking at the LA County Jail, 20% are considered mentally ill. And I work in the jails, and so I can attest to, just anecdotally, there are a lot of severely mentally ill. And then, so what happens is the police becomes your main emergency responders for psychiatric emergencies. Hey, sorry. Okay. So now we're going to really talk about, for California, well, actually all states basically have the same formula. So it has come down to that one can be involuntarily hospitalized if they are showing signs of danger to self, danger to others, or grave disability. So the grave disability part is where many of the states have different language. And so I'm going to be working, I'll show you what we did with the California, because most of the states include what California has. If you look on this slide, this is it. A condition in which a person, as a result of a mental disorder, is unable to provide for his or her basic personal needs for food, clothing, or shelter. And I put not arrested because if they're arrested, it's a little bit different. And so that is looking, and again, you can go to the web link at the bottom of your of the page in blue. It says you can click on the state standards for involuntary treatment. You can look up your own state to see what your standards are. And I've included in this presentation, we'll look at a couple of other states other than California. But California is the minimalist version of all the other states that I've looked at. And I think it's because the civil liberties people had such a stronghold in California that we ended up with the most minimal of a law. So interestingly, I have learned that you have to stick to the wording of the law. So for example, the most vulnerable people that we see are, yes, the severely mentally ill, but usually the ones that are showing some kind of medical deterioration. Those are the ones that die first. And yet nowhere in this definition includes that. So for example, in California, we actually have a California senator who's trying to include inattention to medical need as reason for grave disability. Now, for example, we'll show where some of the other states do include that. So what happened was we actually created, we got together, and this is something that I would encourage you to mimic in your individual counties, is we actually brought together all the important people. So Department of Mental Health, Department of Health Services, the LA Housing Services Authority, deputies from the Board of Supervisors, and different advocacy organizations. So all the people who are important in creating advocacy and policy, we brought them all together, and one of basically with the intent to say, this is a problem, we need to address it, and what are we going to do? And so one of the action items that came out of that large meeting was creating a small work group for defining grave disability. So basically, you can do the same thing for interpreting, because not every state calls it grave disability, but interpreting your law for involuntary treatment beyond danger to self and danger to others. So things that we wanted to include was including the person's inability to understand as a part of grave disability. We wanted to include their past history, and we also wanted to include what's called a need to treat standard. So many of the states already include a need to treat standard in their law, but what it basically means is this person is deteriorating and eventually they will become harm to themselves. So it's not imminent harm, it's eventual harm. And they also are unable to make informed medical decisions, and they're not seeking the needed psychiatric or medical care at the time. So this is not part of the California law. However, it is included in our assisted outpatient treatment law. So most states, I think there's 5 that do not have what's called an assisted outpatient treatment program. And so that's something you can look up for your state. I think Tennessee, for example, does not have one. I just happen to remember that one. But most do. And you can see that there is verbiage in our outpatient treatment laws so that's what's in orangey red, where need for treatment does exist. So when you are trying to come up, if you're trying to come up with new laws or legislation, you can show that, for example, for California, we do have need to treat language for outpatient treatment. And so assisted outpatient treatment, basically they need to have had a certain amount of hospitalizations and or a certain amount of incarcerations. And this is a forced outpatient treatment, but we're not, I don't want to go too much into that, but in the end, if you have more questions, we can talk about it. So basically, my goal, and I'm assuming you guys have the same goal, is to have high quality humane care for the severely mentally ill. This is a patient of mine from Skid Row who actually, we were able to get her into that county mental full service program, the willing one, because she was hospitalized for her medical reasons. We were able to get her on psych meds while she was in the medical hospital, and then she was willing to take help from the full service program. And she ended up getting housed, and she died about 3 to 6 months later from end-stage liver disease. But anyway, I just wanted to include that there's the moral reason behind why we do what we do. So interestingly, if you look up grave disability interpretation, the first thing that pops up is the Jewish Family Service. And it's pretty much the only thing that pops up. So for California, I didn't really look into other states, but for California, there's really no interpretation of the law. There's no regulations. There's just that one sentence that we saw before. And so we actually took some of the language, what's in red, we used that for our own interpretation. And when we started, we actually had maybe 5 points per issue, food, clothing, or shelter. But we really, and of course I'll show it to you, but in our work group that we spent about 6 months meeting once a month, and then I had to meet with some lawyers and other people in between to really come up with a working interpretation. But the idea was they wanted something short and sweet, to the point. So we started off with a lot of language, and we ended up with very bullet-sized interpretation. So I think it's easier for the eyes. So I just wanted to just show you some other states where their grave, I'll call it grave disability, but it's basically other than harm to self and others. So, and these are examples of language that we think is helpful. So Louisiana includes unable to survive safely in freedom or protect himself from or herself from serious harm. Washington State includes in danger of serious physical harm resulting from a failure to provide for his essential human needs of health or safety, or manifest severe deterioration, not receiving care essential for his health and safety. So you can continue to read those, but those are states that show language that is more inclusive to the type of patients that we see on the streets. I want to read Colorado's because that's probably the best. And for you Coloradians out there, kudos to you. Incapable of making informed decisions about or providing for his essential needs without assistance is, so the essential needs usually is food, shelter, or clothing, is at risk of substantial bodily harm, dangerous worsening of any concomitant and serious physical illness, significant psychiatric deterioration, or mismanagement of their essential needs that could result in substantial bodily harm. So right there, in comparing it to California, we have to prove basically that someone cannot provide food or clothing or shelter, and then that's it. But here, and this is pretty progressive, to include almost like it's a need to treat, like a deterioration of one's condition to where they will have eventual harm is included. So those from Colorado or other states that include that aspect of the language should really start looking to see, are the people in your state using the law? So that's the other important thing. When looking at the Treatment Advocacy Center, one of the research papers that they presented is they actually looked at every single state and they graded them. How did they do in regards to having emergency evaluation, for example, the police or psychiatric emergency response team in the streets, how they did with inpatient involuntary treatment, outpatient involuntary treatment. But then they also looked at how well are they following their own laws, and everyone did really poorly. And so that's another thing you can, when you later, if you want to look at the Treatment Advocacy Center's website, go to the Mental Health Commitment Laws, a survey of the states. California did the worst. We got F's across the board. Believe it or not, Idaho did the best. North Dakota did not so bad, and North Carolina did not so bad. But in using the law, most people did very poorly. So another aspect of what you can do is advocate that actually your psychiatrist and the legal team, public guardian, that all those people are actually following the law. So that's why it's a good idea to get this small group to really look at what does the law say, so that everyone is on the same page. So the police are on the same page, the paramedics are on the same page, the psychiatrist in the ERs are on the same page, the psychiatrists in the inpatient hospital are on the same page, public guardians on the same page, legals on the same page, and then hopefully the judges, they kind of have their own opinions about what's worthy of conservatorship. But the hope is that if everyone's working on the same page, the judges will assimilate that into their own decision making. Okay, so for California, I'll just give, we'll just use this as an example. This in red is the existing law, and what's in yellow is our interpretation. So obviously suffering from a severe mental condition. We said that they're incapable of making reasonable decisions and lacks insight regarding providing for essential needs without assistance. And then persistent lack of ability to care for one's basic needs, such as securing food or clothing or shelter. So I also want to make sure that everyone understands the or. So most people are saying, well, if they're homeless, aren't they gravely disabled? So my answer to that would be yes. So that's where the advocacy of everyone getting on the same page as to what is grave disability is really important, because if you talk to a psychiatric emergency response team member they would not necessarily look at these as their opinion of what grave disability is, for example. So this is our interpretation for California. And just so you know, the LA County Department of Mental Health has been a part of this process. They are in favor of this, so it's really important to get them on board. We also had deputies from the Board of Supervisors. So for LA County, we are governed by Board of Supervisors who are actually extremely powerful. And a lot of times what LA County decides or comes up with affects the actual state laws. So, so basically, food incapable of accessing and consuming life-sustaining, adequate, and unspoiled food and potable water, and this is important, on their own. And the reason why we say that is because a lot of times people say, well, if I give them a hamburger, they're going to eat it. But what if you don't give them a hamburger? And then, you know, or if it's snowing outside or raining and people aren't around to hand them food. So it's really important for us, and that everyone was in agreement that it's on their own. And then the other aspect is evidence of malnutrition and or dehydration. So if you can document that you've been you know, outreaching a specific patient on the streets, and you've noticed that he's developed, that he's getting thinner and thinner, and you know, has temporal wasting, and you're documenting that, that's evidence of malnutrition. Clothing. Lack of clothing, this is pretty straightforward, nudity or partial nudity. This is the more important part, is that someone is showing evidence, and I would say evidence of near exposure, so we don't want to wait till they get frostbite, but if they're en route to be having frostbite or trench foot or hypothermia or hypothermia. So for example, we had a woman in Skid Row who's severely mentally ill who last year when we had, you know, 3 days of rain in a row, she wouldn't get out of the rain, and she died of hypothermia. And so the cop, when he was interviewed, said, well, I can't force her to get out of the rain. And actually, if you look at the law, you can force someone to get out of the rain. So again, this comes down to everyone getting on the same page for what needs to happen in order for the first responders to take action, but also everyone else up the line of hospitalization and conservatorship. So keeping notes and keeping track of every engagement and every time that they've made a decision that you think has created more harm or potential harm for them is really important. And then shelter. So this is what we came up for shelter. So this is actually 2 points. The bullets didn't show up, but incapable of securing adequate and appropriate shelter, and this is the kicker here, appropriate for the weather and one's safety. Okay, so that's, you know, especially for those of you, you know, not in California or Southern California, you know, that's something that you can easily prove that one is at risk when they refuse to get out of severe weather. And then this is the other one, shows repeated and recent history of failure to maintain and sustain adequate shelter due to their mental illness. So if someone's being offered shelter, we even had someone that we got her an apartment, really nice apartment in a really nice building, and she refused it. And she can't tell us why she refused it. So this is someone who's a really good example who is gravely disabled because she cannot maintain and sustain adequate shelter. Okay. So that's it for California when it comes to the law, and what I would do for each of you in different states is have your own version of interpreting your law. And for example, someone in Colorado, you're going to have more wiggle room and more oomph to really advocate for your people to be involuntarily treated. So what we did is, because I wanted to include those who were a danger to self because of their medical conditions, and the lawyers, I was in a room with 5 lawyers, and they all had their law books out, and they basically said, you cannot add language to a law. And of course I was like, well, what about the essence of the law? And that didn't work. So you cannot you can't add or detract from the word. So what we did is we interpreted exactly what was there, but then what we did is we came up with a vulnerability list. So what we are saying as a team of experts, and there is not a lot of evidence behind this, so this is where, it can get a little controversial, but we as a team of experts decided that so once we've decided that someone is gravely disabled, because, LA County has over 50,000, homeless per night. So, if we say even a quarter of that are severely mentally, even a tenth of that severely mentally ill, we can't handle involuntarily treating all those people. So what we're saying is, say someone is gravely disabled because they're homeless, we're going to add an extra aspect to their grave disability and say, we're considering them gravely disabled, and now we're giving you a list of who we think are the most vulnerable for death or morbidity. So these are the topics that we included. So people who are at risk for substantial bodily harm. So we'll start with kind of the easier things, hygiene. So if someone is covered in feces, vomit, urine, or blood, we're going to say that this person, in addition to what we considered was gravely disabled, is now even more vulnerable, because this pretty much shows the extent of their psychiatric condition, right? Unable to keep from severe infestation. So now you're saying that everyone, once we get to this, everyone, is included in this list. So lice, scabies, vermin, maggots. Continuing with substantial bodily harm, and this, probably has the more oomph, and I'm apologizing for the gross slide, but just trying to wake everybody up. Lack of self-care, so it says there's a dangerous worsening of serious medical conditions. Now, many of the states already have that in your law, and so you can advocate to use that to hospitalize someone. We do not, California does not have that in our law, and so we are going to include someone who is not attending to their serious medical condition as a vulnerability. So someone who's losing a lot of weight, someone who has serious open wounds, serious skin infections, so that's my example. Someone who's altered or delirious or disoriented, someone who lacks capacity to make medical conditions where no treatment would lead to substantial bodily harm. Oops, sorry. So we'll get to what that means in a minute. But so now we're not just talking about imminent harm, but we're talking about refusal of care which would lead to eventual harm. Okay, so I just wanted to just go back. So we said that someone who lacks capacity to make medical decisions where no treatment would lead to substantial bodily harm. So that's where we're talking about lack capacity. And so this is just to remind you guys that you can use this. It might even be included in your law, in your state's law, not in California's, but you can definitely use the criteria for not having capacity to make medical decisions as a reason to why someone is super vulnerable and needs to be hospitalized. So first of all, they lack insight into their medical condition. And so this is, if you boil down, there's actually literature behind this, and this is what psychiatrists use. And of course, it's after full disclosure and without coercion. They need to communicate a choice. So they have to say yes or no, I want dialysis. Okay, we'll use that as an example. You have to understand why dialysis is important, and they can explain that to you. They have to appreciate the situation and its consequences. So what do you think would happen if you didn't take dialysis? What do you think is wrong with you? And then if they say no, what is your reason? What is your reasoning? You know, well, I have to go pick up my check, but I'll come back the next day. That's kind of reasonable, right? But if they tell you that the demons tell you that the CIA is connected to the dialysis unit, and if you use dialysis, they're going to come out after and get you, that's not a reasonable engagement of processing the information, okay? So there's probably a whole talk behind criteria for decision-making capacity, but that's just to give you a little taste. Okay, so so we talked about hygiene, infestations, and medical care or inability to attend to their medical conditions as someone who's being vulnerable. And then we're also going to include showing signs of significant psychiatric deterioration as evidenced by worsening symptoms of psychosis or severe mood disorder, highly agitated, physically or verbally aggressive. So again, not imminently at harm, but eventual. And then we're also including someone who continuously puts themselves in high-risk situations. So for example, for example, we have a woman who roams Skid Row. She's Caucasian. She's by herself, and she continually gets mugged and beat up and bruised. And so that would be an example of someone who's continuously putting themselves in high-risk situations, or signs of known history of repeated battery, assault, rape. Those are some examples. And then we also want to look at chronicity. How long have they been there? They've been there 15 years in the same spot. This is someone who's going to be vulnerable, and then of course the elderly. So those are our what we came up with as far as a vulnerability list. So what we did from the grave disability list and the vulnerability list is we came up with a crisis response checkoff sheet. So this is where all the money is, and this is something that the Department of Mental Health was very eager to have, and I'm actually meeting with him this Friday to kind of present everything to him and give him a tour of Skid Row. But this is a way of training first responders. It's also something you can use for documentation. So if you want to use this as, you know, we've attempted 10 times because we felt like they've satisfied this checkoff list, that could also be used as documentation. So in red is what needs to be present. So when we say LPS standard summary, that's our involuntary treatment code. So they must demonstrate a mental order. So that needs to be checked off. Secondly, if they're, so a danger to self is obviously one of them. And, you know, you can kind of see what we included in that. But that's usually a given. Danger to others is also usually a given, meaning these aren't the areas that we have difficulty in treating people. So the fourth issue is, so they have to be mentally ill, and if they're not a danger to self or others, then they have to be gravely disabled in order to involuntarily commit them. So here's the checkoff list that we came up with from the interpretation of the California Code. And so you can come up with your own checkoff list, but basically, are they able to access adequate unspoiled food and water? Do they look malnourished? Do they look dehydrated? Are they nude or partially nude? Do they have evidence of exposure? Do they look like they're sweating and they're in the heat and they're covered in multiple jackets and it's 100 degrees outside? Or do they lack clothing and it's freezing outside and they're shivering? And then we added an other in case there's something we forgot. Are they able to secure shelter for themselves? Or are they showing repeated history? So basically what it was the law said, we put it into a checkoff list. But then we also included the vulnerability list. So this is not what is considered gravely disabled for California, but we're saying that any of the following increases their risk of morbidity and mortality. And it's really just one checkoff, but obviously the more checks you have, the more in danger they are. So, you know, you'll see they're placing themselves in repeated high-risk situations, they have worsening of their psychoses, they have the evidence of bodily infestations, significant, are they covered in blood, feces, and urine? Do they have an untreated medical condition? Any open wounds, are they altered? Do they lack decision-making capacity? And so it goes through that. And that's our, and that's really what we came up with. I can kind of put some of this, this might be helpful. But, and so that's, so the next step for us would be to come up with a training material or guide or curriculum, and then figure out who we want to train this checkoff list to. And so our first thoughts are all the outreach workers, the police, the paramedics, the psychiatric emergency response team, so that way you can all communicate using the same language. And then the next step would be to orient this to the psychiatrists in the emergency rooms and the psychiatrists in the inpatient hospitals. So that we haven't done yet, but that would be the next step. And as far as getting people conserved, this would be obviously the first step to get them hospitalized. But in order to keep them hospitalized, you really need that advocate. So the person who's been doing street outreach basically needs to be showing up at the hospital in the emergency room, so to explain all the attempts and why they are an eventual harm to themselves, if not imminent harm, why they're gravely disabled. And then they also have to be present for whenever the legal people come to approve a 2-week hold, a 1-month hold. And then also they need to be present when the public guardian gets involved. And then they have to be involved when it comes to the court proceedings. So a huge part of getting someone conserved is having this person or people who are basically their advocates, their voice. Because they can't say, well, in 2003 I had a heart attack and then I had 3 stents given, and then in 2010 I had another heart attack. Like, they can't say that. So we need someone who's going to be their voice. And so that's really important. And when we had that big meeting, that was one of the things that the public guardian said, is that they need to have really good records. And those records need to get to the court. So that's not rocket science. That's more, the outreach teams and the workers need to start providing for those kind of people to exist. So then the next question is, okay, so now we do conserve them. Where's all the housing? Where do they go? So that's another issue, and that's another area of advocacy and policy that needs to be addressed. So LA, we've been given money we actually approved a tax for the homeless, and so we have some money coming in, and I'm still trying to figure out how to spend it. And so, that's where, another step I want to take is advocating for creating more assisted living, boarding care specifically for mentally ill, and including locked facilities if someone needs that. So that's really what we've done so far. So in summary, I really would like to encourage everyone to have their own meaning of how are we going to best streamline care for the severely mentally ill homeless, and starting off with defining grave disability for your own state, and then advocating for everyone to be on the same page to interpret that correctly. Okay, so I think that's it. I think we can do questions now.
Yeah, thank you, Dr. Parsovi. That was really helpful. I'm going to ask one question that was asked multiple times in a variety of ways. And so the question is about how alcohol and substance use or dependence fit into this process of identifying somebody as gravely disabled. For example, someone may fit that definition but without the mental illness part, or they're unable to consent or follow through with certain psychiatric treatment plans due to having a wet brain. Have you seen that or encountered that in your work?
So some states actually include that in their gravely disabled laws. California does not. So you first, in order to be considered gravely disabled, you have to have a mental disorder. So now the question is, and this would be more, for the psychiatrist, is substance abuse considered a mental disorder? They definitely would fit the criteria for the vulnerability. I would think, in my experience, I work with mostly heroin addicts, but of course worked with alcoholics, that many do have a mental disorder on top of it. And I know teasing that out is very difficult. But some of the states, let's see, well, I don't have it right now, but I remember reading some states actually do include that if their disabilities due to a mental disorder or drug use. So you just have to look at your state. But I think you could make the case if someone is putting themselves in persistent danger, or kind of the same thing that we defined in grave disability, not able to sustain shelter, and that they also include those vulnerabilities, putting themselves in dangerous situations or not attending to their medical needs. I would make the case that their substance use is part of their mental disorder, and that it could follow suit. But yeah, that's a really good question. So that would go back to having to advocate for that as being part of the equation.
Great, thank you. We only have a couple minutes left, and a couple more questions just rolled in, so we may have to answer those via email. But what I want to address is, you talked about setting these meetings with quote-unquote public guardians and other stakeholders in the community. Can you define the role of the public guardians and how to best involve people with the lived experience in those meetings and maybe in the creation of their own checkoff list?
I didn't. The second part I didn't hear.
Sorry. So can you define the role of public guardians in California and how to best involve people with the lived experience of homelessness in those meetings, or maybe in the creation of these checkoff lists?
With the what experience? The lived?
The lived experience, so people who have formerly or are currently homeless.
Homeless. Oh, okay. Sorry. Okay, so public guardian, public guardian for California, and I assume it's similar. It might be called something else. But if you do not have family, and someone is deemed as potentially not able to care for themselves, there is a public guardian that is assigned to take care of them. So, for example, in LA, the public guardian is under the umbrella of the Department of Mental Health. So there's multiple people, not enough though, so there might be, say, 80 public guardians for the entire county of Los Angeles for those who have been deemed incapable of taking care of themselves, but they don't have family to really say how they should be taken care of. So the public guardian is the person that is assigned to them by the public guardian ship of the county. And so it usually involves, so that's when it's going in that direction. So say they've been hospitalized more than 72 hours, they've been hospitalized for 2 weeks, and now you're trying to get them hospitalized for even longer because they continue to show signs that they're not able to take care of themselves, for lack of a better word. That's when the public guardian kind of gets involved, and they have their own attorney, and they are the ones who kind of say, yes, I agree that this person should be conserved, and then they will try to, so they would be on the public, not the defender, the prosecutor's side of trying to get this person conserved. So that's why it's really important that they have as much information as possible in order to try to get someone conserved, if they really believe that they need to be conserved. And I forgot the second part of the question.
Sure. So it's how can we involve people who have formerly been or currently are homeless in this meeting process?
So including consumers is what they're talking about.
Yeah.
The thing is, this was, I mean, as someone who can, as someone who can attest, I think that would be very powerful to have former severely mentally ill, well, severely mentally ill homeless who have been treated. I think that would be powerful in a meeting like that. However, usually the people in those meetings are in a, well, the experience we had is that everyone agreed that there is a problem and something needs to be done and not enough is being done. So it was really a meeting of those who can advocate and create policy the best. But it was really good to have like our outreach workers who are giving examples, and we did slides and case presentations of people showing how dire the situation is. But to, as you know, to include someone, you know, if they want to discuss how severe things were for them and that they didn't realize how severe it was until they got treated, I think that would be very powerful. And so just inviting them would be would be the way to do that.
Great, thank you. We are at the top of the hour, so I apologize for any of those lingering questions. If we were unable to get to them, we'll try to get those addressed via email. But thank you for joining today's webinar, everybody. A link to the archived webinar and PowerPoint slides will be available on our website at www.nhchc.org at the conclusion, probably within 3 business days. And at the close of this webinar, an online survey to evaluate the webinar will automatically open in your web browser. If you could complete that for us, we can help improve our webinar experience. This meeting will now be closed.